Good afternoon, everyone. This is Dr. Curtis Campbell. Welcome to the webinar. Thanks for joining us. I'm excited today to be talking to you about hip and knee pain, but more specifically, some advances with hip and knee replacement with robotic surgery. Just a little bit about myself. I'm currently part of the Connecticut Orthopaedic Institute at St. Vincent's Medical Center and in practice with Connecticut Orthopaedics, specially trained in total hips and total knee replacements. There's no disclosure. We always have to do, if there's any disclosures or anything to report, nothing in terms of consulting or financial arrangements related to this presentation. So today's talk, really, I'm going to try to make it as interactive as possible through the webinar. So as Billy mentioned before, there's an option for you guys to ask some questions. So if anything comes up that's on your mind, I want to make sure that you get everything out of this that you came here to get. We'll try to, in order to be more efficient, we'll just try to do all the questions at the end. We'll make sure we address everybody's questions as they come up at the end. So just a brief outline what we're going to be talking about. We're going to talk a little bit, first off, just talking about joint pain, arthritis. We're going to talk about some treatment options, most of which still are non-surgical treatment options. Then we're going to go into some joint replacement options. What to do when your pain is getting too bad. Specifically with that, we'll go over the robotic advances that we use now for total joints. And then we'll go over some recovery expectations at the end, what happens after your joint replacement. And we'll leave plenty of time at the end for questions. So your joints really are involved in pretty much every activity you do. When they're working well, you don't really think about it. You're going on with your day-to-day activities, but even just a little bit of pain in your hip or your knee or any other joint can really sideline. It can interfere with your activities at home, going to work, playing with your grandkids, and it really can limit you on a daily basis. So what are some of the most common causes of joint pain? We think of joint pain, we're thinking really of our arthritis, and arthritis is any type of inflammation or injury to the joint. In this lecture, we're talking mostly hip and knees, but it really can occur in any joint, your shoulders, your elbow, your back. The most common arthritis that we talk about usually is osteoarthritis. That's more of the wear and tear kind, or the degenerative arthritis that over the course of years and the amount of force and activity level you put on your joints, the cartilage tends to wear out over time and eventually gets to the point where it could be bone rubbing on bone type arthritis. Another type is rheumatoid arthritis. That's more of an inflammatory, so it tends to be more of a systemic kind of condition that you have more from an early age. That tends to affect more than just one joint. And that's often treated somewhat differently earlier on with some different types of medications, but ultimately can still end up in severe arthritis. Post-traumatic arthritis, so say if you have an injury earlier in life, whether it's a fracture that extends into the joint, or maybe you had a meniscus tear that later sets you up later on in life because you lose a little bit of the cushioning in the knee. Later on, you get some arthritis. Same thing if you have, say, like a ligament tear from playing sports when you were younger, like an ACL, that later on can lead to arthritis. And there's lots of other types of arthritis. These are some of the more common ones. And really, if you kind of look at the bottom here, really up to about 55 million Americans are facing arthritis, which is a fair amount of people that are kind of going through on a day-to-day basis with pain. So what are, so now that we say, you have arthritis, what are some things we can do for you? Most of this is going to be, non-surgical. We always start off with that. Some possibilities include, walking aids, meaning, a cane or a walker. Usually you don't need that early on, but that's more if it gets to the point where it's, some of the other options aren't quite working. This can, offset some of the pressure from your hip or your knee. Heat or cold can be very effective, specifically, cold if you're having a lot of inflammation, if you have, a warm, swollen, knee filled with fluid. At the end of the day, it's hurting you. You can ice it, and a lot of times that, makes it feel better. Where on the other hand, heat often can help you if you're feeling, your muscles and your bones and joints are feeling tight. You get up in the morning, the heat can kind of help you get going. A lot of times you take a shower, you feel better, that kind of thing. So both heat and cold have a place here. Physical therapy is very important. A lot of times we can start off with, even before we do physical therapy, just doing some stuff on your own for muscle strengthening exercises, core strengthening exercises. A lot of that is you can just do at home or at the gym. if that's not, effective enough, some formalized physical therapy can be quite helpful where you see the therapist. They can teach you how to have some better posture, how to, offload some of the pressure from the joints, how to build your muscles in your quadricep, your hip, your back. And there's some medication or medical treatments, typically starting with over-the-counter anti-inflammatory medications. This is typically like Advil, Aleve, sometimes Tylenol. There are some other arthritis medications as well, like glucosamine chondroitin. So typically we start off with just kind of taking something from you get on your own over the counter. If that's not helping, or you need a little bit more, there are prescription anti-inflammatories. A lot of them are the same medications you get over the counter. They're just higher doses of them. Other ones are just a different type, where it's maybe like a longer acting one, or one that maybe doesn't interfere with your irritate your stomach as much. If that doesn't work, there are some other little bit more invasive options, such as injections. Most commonly, the cortisone or steroid injections, what we would do first. This is typically, say if you have a swollen knee, a lot of fluid in there, it's you can hardly walk on, you can't bend it. Sometimes you can take some fluid out, or at the very least just do a cortisone shot. And the goal of that is to deliver the anti-inflammatory medication directly to the joint, as opposed to the medications you take by mouth that are more systemic. So this really delivers the medication directly to the joint. There's a gel injection or a hyaluronic acid injection. I'm sure a lot of you have heard about the gel injections. There's lots of different brands of these. They're all very similar. They're all the same type of molecule or protein in it. And the goal of that is that it's really provides a cushioning for your knee. It's similar to the fluid that's in there naturally, so it kind of coats the cartilage, gives you a little more cushioning. And the goal of that is really just to decrease your pain and prolong the time before you need any type of more invasive type of intervention. There are some newer injections that are out more recently over the last few years. These are more biologic type injections. You've probably heard of PRP, or platelet-rich plasma. We do a fair amount of these. I did one of these today, actually. It's somewhere we we draw blood from your arm. We have a centrifuge that spins it down, so we get the very layer of the platelet-rich plasma, which has a lot of growth factors in it. And then instead of injecting a cortisone or a gel, we actually inject that liquid or that material directly into the knee or the hip, with the goal of kind of having some growth factors there that stimulate, some cartilage and reduce pain. Another option that's a little bit newer and showing some more promise also is similar as just stem cell injections, where we can take some of your bone marrow and do a similar process where we kind of differentiate and spin it down and with a centrifuge and get more of like the actual stem cells. That those are more more potential for actually creating cartilage. Again, that's a little bit newer, but we're certainly doing that as well. So the question here is when to consider joint replacement. So most of the time we try to do all those other treatments. A lot of times that's over the course of several months or even years, where you start off, maybe you have some pain and you get better. You do some therapy, then you get better. But some things to think about if you're getting to that point where maybe you're considering a joint replacement. Is the joint affecting your ability to get a good night's sleep? Is it something where at the end of the day you can't sleep, you try to lay down, you can't get comfortable? Is it keeping you from doing the things you want to do? So are you normally pretty active? And now this is kind of sidelining you from doing your normal activities? Is it preventing you from just doing some of the stuff that you wouldn't even think twice about doing, but now you're having a hard time? Are you less active because of the joint pain? Okay, along the similar lines, but this is more, say, if you're you used to play tennis or golf, or you enjoy if you're babysitting your grandchildren, you used to be able to kind of get on the floor and play with them, and now you can't kneel down, or you can kneel down but you can't get up. These is again to that point. And then also when we talk about stairs, the arthritis puts a lot of stress kind of going up and down stairs. You're at the point where you can't really get up and down throughout the day. If you answer yes to all these, mostly, then you might be at the point where you're considering a joint replacement. And I usually tell patients, you'll know when you're ready. I mean, this is something that you're kind of dealing with for months or years, and if it gets to that point where it's interfering with all the stuff you want to be doing on a regular basis, then it's probably time to at least consider it or get some more information about it. So we're going to talk a little bit about total hip replacement now. We'll kind of do a hip replacement, knee replacement, and then some partial knee replacement as well. So this is the slide with just some of the anatomy for the hip. On the left-hand side, this is what a healthy hip looks like. So here's your, just to kind of give a reference, here's your sort of the bottom of your spine as it turns into your pelvis. The hip joint is a ball and a socket joint. So on the socket side is your acetabulum or the cup. On the other side, on the top of the femur is the ball. So when this gets totally worn out, if you look over on the right side now in this box, instead of looking nice and smooth where this white cartilage is over here, when this is really worn out, you get bone spurs, you get cartilage wear as bone rubbing against bone. That's essentially what arthritis is losing cartilage as the hip degenerates. Here are just some x-rays where we, on the left-hand side, we have a nice healthy looking hip where there's a nice round ball. That white line is a socket. That space in between here is your cartilage. That looks nice and healthy. Whereas you come over here and you see that that space is completely gone. There's no cartilage left. You're getting bone spurs and cysts. The ball actually sometimes even kind of pushes out of the socket a little bit, depending on the type of arthritis you have. This is just a quick video. We'll see if this works. There's no sound on it, so it's more just to kind of give you a demonstration of. Let me see. If it doesn't work, it's not a big deal. Here we go. So this is just going to be real quick. Yeah, so just an anatomy of the hip. So this is the muscles of the hip. We get down to the joint. This is that ball and socket joint that we're kind of talking about. So essentially for hip replacement, you're replacing that whole joint. So remove the ball, put a new socket in. This piece of plastic acts like the new cartilage, a new stem that goes inside the thigh bone, and a ball that goes on top. So the hip joint is replaced with a metal or ceramic ball that articulates on a plastic socket. And this is another picture of that on the right here. So there's the pelvis, the hip implant, which is the ball in the socket. So we're basically essentially removing the arthritis. So this is something where it's not like you're just addressing the pain or making things better. You're actually physically removing any remnants of bone or cartilage that are in there. So the arthritis technically is gone at that point. Here's just an x-ray to show what it looks like after. So the normal hip on this side. The white you see on here is the metal, the ball in the socket on the left side. And there's just another demonstration of what goes into the hip. So essentially it's the ball in the socket here, but the ball has to lock onto the stem and the socket has to lock onto the pelvis here. So in terms of hip replacement, there are several different ways to do it. Traditionally, the way everyone was first taught, years ago, was a posterior approach where you go through the back of the hip. But since then, there's been more advances in terms of different approaches to get to the hip that minimize some of the risk factors. We consider this, the muscle-sparing approaches to be a little bit better, where we don't have to cut all the muscles around the hip. We can find some natural intervals to go between muscle and get down to the hip joint. The direct anterior approach is one of those approaches. This is my preferred way of doing hip replacements. This has actually been around for many years. It's been more popularized recently since probably the early 2000s, where it's become more common to use for hip replacements. But the surgery itself is the same. We're doing the ball in the socket and replacing the joint. But instead of going through the back, where there's some limitations and of potential side effects or complications of the hip dislocating, the leg length not being exactly the same length. Going through the front, we don't have to cut some of those same muscles. So there's much lower risk of the hip dislocating or coming out of place if you put it in a certain position. I find it's easier to kind of make sure your legs are the same length. So we have you laying flat on a table, and I can kind of literally just kind of feel your ankles and your feet and make sure they're even. We can use x-ray or robotics to kind of confirm that as well. So I found that the results with this have been definitely better than with when I do when we used to do it with a posterior approach. Total knee replacement. So here's just another depiction of more some anatomy. So on the left-hand side, here's a healthy looking knee. So the top part is your thigh bone or your femur. This is your kneecap or your patella in the middle. This is your tibia or shin bone underneath. And in between that is this whole area right here is the joint. So the white you see here is the cartilage, and there's a meniscus in there as well, which is the soft tissue cartilage. Arthritic knee, if you kind of look over here, it's sort of the same picture, but when the cartilage wears away, you see that this red area here and throughout the knee. That's actually some exposed bone underneath the cartilage that is what really becomes painful, because cartilage itself, when it's healthy and it's intact, doesn't really have any nerve fibers that cause any pain. But when the cartilage wears away and the bone gets exposed, that has a lot of very painful nerve fibers at the end of it. It can lead to a lot of pain. There's just, there we go. Here's a couple x-rays, just again demonstrating a healthy knee. On this side is where if you come to the office, we get some x-rays of your knee. We usually get them with you standing up, because when you lay down flat, that can compared to when you're standing, there can be a difference in your joint. When you stand up, you can maybe lose some of the space in here on the x-ray just because the cartilage is in there, where you might not realize that if you're laying flat. So this is the healthy space in the cartilage. If you come over here, you can see there's complete loss of half the joint space on this knee, where this side is a little narrow, but not quite as bad. One of the things to really like to tell patients about in terms of the knee and how much force goes across it is that, with the way the knee is designed, with the patella, it actually sees, this slide we say up to 4 pounds, but in some studies it's been up to 5 or 6 pounds. So every time you step, your kneecap and your knee joint feels 4 to 5 times the force of your body weight. So if you gain a couple pounds, your knee sees a lot of weight. Where on the other side, even just a little bit of weight loss, like 1 pound of weight loss, it means your knee feels 4 or 5 less pounds every time you take a step. So it can, even just very little bit in either direction can make a big difference. Here is a video, similar video. This is for the knee instead of the hip. So we'll see if we can get this to work. Yeah, similar concept. So here's the knee right here. Muscles in the knee joint. You can see where the knee is bending. So what we do is we get rid of that bone and cartilage. So you're going to see this is cutting away all the joint surface. Put a metal cap on the femur. Put a metal cap on the shin bone or the tibia, and a piece of plastic that goes in between. So your new joint becomes the metal and the plastic bearing surfaces together. So that takes the place of the cartilage, and we really only remove a certain segment of bone, just enough to get rid of all the bad the cartilage and bone that's in there. Here's just another depiction of it. On the right side is a total knee replacement, where we replace everything. Partial knee replacement, you've probably heard of that. So that's another option as well. So say, with a total knee replacement, there's really 3 parts of the knee, or 3 parts of the joint. There's kind of the inner half, the outer half, and then the kneecap part. If only one of those has arthritis in it, then you don't necessarily have to replace the whole joint. A lot of times you can just replace half of it. So you can see over on the left side, only half the joint is replaced here. And this is a slide kind of depicting the different types of partial knee replacements. So say if you only have the inside half of the joint, the medial side that's degenerated, you can do a partial medial replacement. If it's the outer part or the lateral, you can do that side. If it's just the kneecap, you can just do that side. And this is what a partial knee would look like on the left. So I guess we'll look at the right one first. The total knee replacement, you can see all the white you see is the metal replacement that's in there. So you can see the whole joint, the whole part of the knee is replaced. Where on this side, you can see just the half that was diseased with arthritis, whereas the other part looks really nice and healthy here. These are just a couple of examples of partial knee and a total knee. One specific type of implant called a triathlon is the one that I typically use, and that's designed where it just has a very constant design or radius of curvature. So I find that you have just a lot of full stability throughout the whole range of motion. So the goal of the knee replacement is to get you a knee that's pain-free, stable, and good range of motion. So we like to try to get you the same motion or more motion you had before, so it stays nice and balanced throughout the whole range of motion here. I know we do have a poll question, so this might be a good time to post a poll if we haven't done that yet. I know I can't quite see the polls yet here, so I just want to, it's a good time to take a break. Not a break, but just to list a poll question which I think looks like it was just posted right now. So everyone just kind of take a look at that. We're just kind of asking about, any type, your hip or knee pain. It would just be, it should be just simple yes or no answer. So maybe take a look at that and answer that and respond when you get a second here. So the next part of the presentation here. So now we kind of talked about arthritis, different treatment options. We talked a little about what joint replacement is. I think one of the biggest advances in the last decade or so with joint replacement has been has been robotics. So what that is essentially is really doing the same thing. We're doing the same hip and knee replacement. And the only real difference is that we have more information. We have some technology now that allows us to be more accurate, more precise, be more reliable. So let me see. I was just kind of looking at the poll here to see if. All right. Yeah, so just kind of looking at the poll now. So do you currently suffer hip or knee pain? So far, it looks like most of you have. So 88% are saying yes, some type of hip or knee pain. So it's probably why you signed up to watch the webinar, probably. All right. All right. But yeah, that's how common it is too. I mean, we were definitely finding that people are having more hip and knee pain. A lot of times it's because either you're more active or doing more, or some of the arthritis we're finding starting at an earlier age as well. So the majority of people at least have some type of hip or knee pain. So going back to the robotic part of it here. So what robotics is essentially, we think of you're always trying to get better, try to do things more efficiently, try to be more accurate with technological advances. So that applies to hip and knee replacement as well. So what we do with the robotics, there's different systems out there. The one that I use is called a Mako. We have that at St. Vincent's Medical Center. And what we do essentially is we have some more information. So how we get the information is, in addition to the regular, just the x-rays we get for your hip or your knee, we get a CAT scan before your surgery. So that gives us a whole 3D image of your pelvis if we're doing the hip replacement, or your knee if we're doing a knee replacement. So that allows us to plan much more before the surgery. So we really know going into it exactly what size implant we're going to use, what fits your anatomy. Everyone's a little bit different, so we can tailor it to exactly what's right for you. For the hips, we can know exactly the size cup to put in, and it really just helps us kind of plan exactly where we want to put that to maximize your recovery, to reduce risk of complications. And then you really just have a better plan going into the surgery. So that's kind of ahead of time, but that's also combined with during the surgery, the robotic, the part ahead of it is really more the computer based, where we're looking at everything and analyzing the data. During the surgery, we're doing the same thing. It's just, the surgeon's doing we're doing all the work, but when we do the bone cuts and placement of implants, instead of just doing that completely by hand or with mechanical jigs and other stuff we normally use, it's actually hooked up to the robotic or assisted arm. So we can program it exactly where we want to cut with 3 degrees in one position and 10 degrees in another angle, and we cut exactly where we want it. So it has this AccuStop or haptic technology, which is the term for the robotic part of it, where it only lets us cut things exactly where we want it. So we know with certainty that we planned your surgery, we want it in a certain way, and the implants go exactly in that position. In addition, there's a lot of feedback during the surgery. So more so with the knee replacements, we actually take your knee through a range of motion, make sure you have full flexion, full motion, full extension, make sure it's nice and even and balanced throughout. And once we have it exactly where we want it, we kind of lock in the program, and the robot only lets us cut it exactly where we programmed where we want it to go. These are just some of the benefits. So this can be used for all the types of joint replacement we talked about so far. So it'll be for hip replacement, knee replacement, and partial knee replacement. This is, even though we say it's relatively new, it's still been around for a good 10, 15, almost really 15 years or so. So there's still a fair amount of data on it. So based on some of the studies we've seen for the total knee replacement, we find that there's definitely some lower pain scales. There's less damage to some of the soft tissue. We really end up cutting less bone. So because it's more precise, we know exactly where we're cutting. It'll be even less, little bit more muscle sparing, tissue sparing, and bone sparing. Similar to partial knees, it's find there's a little bit quicker recovery, less time in the hospital. Total hips, we found you get a little more of a natural feeling hip, and really with the hips, the accurate replacement of that cup. And the biggest thing we worry about hip replacement is it not being stable or possibly dislocating. And one of the most important factors for that is getting that cup in the right position. There's a certain range we like to have it in. Is even though we're good at kind of visualizing that by by X-ray or by just by looking at it during surgery, the robot makes it even more accurate. These are just some numbers just to kind of, nothing too important, anything you need to remember or anything, but just knowing that, it's been around for 14, 15 years or so. There's over 300, this was from last year's data, so even last year there were over 300,000, robotic or Mako and hip or knee replacements done, and that's growing. So there's definitely a large body of evidence showing that this works. We'll see, this is a video, I'm not 100% sure if this video will work. This one is a little more in depth, but I'm gonna try. If it doesn't, it won't be a big deal. Yeah, so this one is, again, there's not really sound on it, so I'll just kind of explain everything. So this one's just more about the total knee with the robot. So this is the CAT scan you get before the surgery. So it gives us even more information. So it gives us a 3D image of your knee that we talked about. And this is kind of what it looks like we're looking at. So this is our software program where you look at all these different numbers and make sure the knee is balanced and fits well. This is all done. This is all done ahead of surgery before we even get into the operating room. This is the surgery part of it. So this is the interactive part where we're kind of using some sensors and robotic sensors to identify your specific anatomy and match that with a CAT scan that we got ahead of time. Yeah. So this part of the surgery is where we actually use the computer and the robotic software to really balance your anatomy. We take it, bend it sideways one way or another, make sure it's nice and balanced. This is where we make the cut of the bone. So this green line is essentially kind of the robotic boundary. It's not a true boundary physically, but we kind of cut to go past that. The robot actually stops us from going there. So, and that's all again based on what we planned ahead of time. We can see as we're cutting, to use like a visual cue where the green goes away and we know it's gone. And then we're just putting the knee once that's done, put the knee replacement in just like we would otherwise. And then we start your recovery and physical therapy after that. So, and that's just a picture of the actual robot, so you can see there are instruments attached to the end of it. Right, so just to kind of go over some of the steps, that was kind of a quicker video, but the first part is we develop a personalized plan just for you where we get the CAT scan ahead of time. We use the software to look at your knee or your hip, figure out what size implants we're going to use, balance your knee, and have a dedicated, a predetermined plan for when we get into the operating room. We make some subtle adjustments to once we're in there. We cut the bone just like we would, but using the boundaries and the plan that we'd use, assessing stability, range of motion, and then we put the hip or the knee in place. So we kind of talk about with this, it's, we know more, meaning that we have more information with the CAT scan, which allows us to kind of actually cut less. So we cut less bone and are definitely more precise and more accurate. This is just a similar slide that we showed before, the different types of partial knee replacements. And this is the robotic options are an option for every type of one of these, the hip, the knee, or the partial knee. Just to talk a little bit more about the partial, this tends to be done more if you're maybe a little bit younger, you only have a little wear and tear in one part of the joint, one out of the 3 areas of the joint. But it's a little more technically demanding just because it's a smaller incision, smaller area to work with. So it really depends on being very technically accurate. So we found that the robot certainly helps more with that. A little bit better outcomes in terms of component placement, balance, and recovery. And they tend to last a little bit longer when they're done robotically than if they're done just by hand. With a total knee, similar, the things that we worry about, even when we do a nice job on doing a total knee replacement, we think everything, goes well. There's still things to worry about, infection. That's something, there's certain things that we can control, like you used to have diabetes, smoking, overweight. But other factors are, still kind of out of your control. But other things like, malpositioning or balancing of the knee, those can really lead to a painful total knee. Up to 10 or 20% of patients sometimes just still have a painful knee after surgery. So we find that the robotic part really helps us with getting that alignment right, getting the balance right, and having more of like a real natural feeling knee. So again, with the knee, with some, we find there's definitely some less soft tissue damage. We find that you need less pain medication or less opioid pain medication after a little bit less time in the hospital. You're able to get home quicker, and your therapy is a little bit easier and a little bit less painful. And then similar with the knee, with the hip, some of the things we worry about, similar, infection, loosening, fractures. A lot of that, some of these problems with loosening. Probably, wear, which is just when the plastic wears out, dislocation, and technique error. Those all tend to be related, somewhat directly to the actual technique itself or placement of the implant. So we feel more comfortable coming out here that we know that we put everything exactly where we want it to be. So we definitely minimize the risk of those types of complications. So just along those lines, similar results where there's favorable short-term outcomes. There's different scales that we use to see how you're doing after surgery. There's one that's called a forgotten joint score, which is kind of an interesting name. It kind of looks, you think about it, if you kind of forget about your joint that it's there, that's a good thing. That means it's doing well. So there's a survey that kind of goes along those lines. It's shown to be much better with after the robotic use of hip knee replacement. So this last part of the talk here, so everything so far has kind of been more of the technical stuff and the arthritis and the joint replacement itself and the robotic part of it. Now we're just going to talk a little bit about recovery after joint replacement, and then we're going to open up to questions after that. So now that you've had your surgery, what can you expect? So just to kind of go over, even kind of leading up to it, there's a lot of stuff to go into it. We really maximize your any medical conditions you might have. We have you see your medical doctor, get some basic labs and EKG leading into it. The day of surgery, typically you have your surgery, you go to the recovery room, usually there for about 45 minutes, and then you go up to the orthopedic floor. At St. Vincent's, we have a dedicated orthopedic floor. It's the Connecticut Orthopaedic Institute at St. Vincent's, and it's a brand new floor. There's actually even more construction going on right now that's going to be expanded even more, but it's all, you have your own private room. We have a dedicated physical therapy area, and typically, on average, you have your surgery and you stay over, stay one night in the hospital and you're home the next day. We're finding a lot of patients actually going home even the same day now. And some of that's just based on, typically if it's, maybe a little bit on the younger side, no real medical problems, more eager to kind of get moving. We find that a lot of times you certainly recover better at home. So if you're doing well, we have the therapist see you. If you're comfortable, you can go home, and then we set you up with some home care with therapy at home. If you stay overnight, typically what people tend to be surprised about is that you're walking the same day of surgery. So typically your surgery is going to be in the morning or at the latest kind of early afternoon. So that way you have time to get up to therapist. You're walking that day. You're potentially going up and down stairs that same day, and then typically you get home. Discharged to home the next day. Some of the biggest advancements in hip and knee replacement over the last few years, aside from some of the robotic stuff, is really has to do with pain control, more so with the knees than the hips. Any surgery, this is a major surgery. There's risk with it, and there's pain associated with it. I like to, think of it as kind of pain with a purpose. Meaning, you have a lot of pain ahead of time from the arthritis. That pain should be gone, but then you're gonna have some pain from the surgery, and then once you recover from that, you should be kind of back to a pain-free state. But with the pain control, we do typically a spinal anesthesia, which helps kind of numb your legs for a few hours, for the surgery. And then when you wake up, you kind of, it starts wearing off. We do 2 different nerve blocks for the knee that numb different areas in the knee, and those tend to last, potentially, several days. And we also use a long-acting injection or like a numbing medication or like a Novocaine we inject directly into your knee during the surgery. That one's actually dissolved in some little fat droplets that over the course of several days kind of slowly release the medication instead of it all being released at once. So that tends to give you some good pain relief for 2 or up to even 3 days. Once you get discharged from the hospital, about 100% of I'd say pretty much about 100% of our patients go directly home from the hospital. Very rarely anymore do we have to have patients go into like an inpatient rehab facility. We find that recover better at home. We're actually a little bit safer for you to go home. We make sure we have everything set up where we have a visiting nurse agency or home care agency with a physical therapist or a nurse to check your wound, to get you doing some physical therapy, and then transition to outpatient therapy after that. Sometimes if it's more of a complicated case or revision or hip fracture, that's when we start talking rehab facilities. But especially nowadays with a lot of things going on and COVID, and I think the less time you spend in an inpatient setting, an inpatient rehab setting, probably the better. We find that the results and complications are better when you go home rather than going to inpatient. Typically, I'll see you back in the office about 2 weeks after your surgery. During that time, it's you're really just slowly working on range of motion, strength. With the hips, the recovery is probably a little bit easier than the knees because it's more just making sure your gait and your walk is normal, your strength is getting better. With the knees, we worry about more just kind of getting your range of motion. Really just want that incision to heal the first couple of weeks. You're typically using a walker or a cane. We tend to see kind of that 2 week visit, and then if you're doing well, then kind of get you going into some outpatient therapy after that. So this slide here just kind of shows, usually hospital one night is a little bit older, that 4 days where it says on there, that's more if you have like like we said, like a fracture or something like that, or revision that might take a little bit longer. Recovery wise, once you get past that 2 weeks, I find by like 2 or 3 months, you're kind of back to doing, most of your, your certainly your day-to-day activities and even your recreational activities. Probably about 4 to 6 weeks, all the normal stuff, walking around the house, going for walks, you should be doing that. 3 months, you're probably starting to do some recreational stuff. Maybe, between 3 to 6 months, if you play golf or something, start doing some, some light swinging, nothing major. But I always say that even though you're recovering and feeling good early on, any major surgery really takes a good 6 or even 12 months till you get your final recovery. You might find that you're, getting, better. You're doing fine at 6 months, but at 12 months down the road, you're doing even better than you were before. You're stronger, you're more active. So in that sense, it's I would say give it a full year till you kind of know the the fullest extent of the recovery. But yeah, so then it's kind of the last part here, just about a lot you might be asking about what activities you can do. So the most important thing to consider with this is that basically we want to get you back to what you were doing before. You're not necessarily going to be doing more things or more physically demanding things, but some of the stuff that is totally fine to do after hip or knee replacement, walking, driving is usually, either 2 to 4 weeks after surgery. Kind of depends if it's your left leg that we're doing, you can drive sooner. If it's your right leg, that's your driving leg, takes a bit longer. But you can certainly do biking, you can do swimming, golfing, some dancing activities, nothing too crazy, but some easier stuff. Stuff we don't necessarily want you doing just because it puts too much stress on the hip and the knee is, downhill skiing. Not that you can't do some of these things, but they just put more stress on it. And when we think about stress and force going across the hip replacement, we just think that that's not going to last as long, can wear out the plastic and the metal in there a little bit sooner than if you don't do it. But long distance running, a little bit of light jogging, that's fine. Any real contact sports aren't ideal. Basketball where there's a lot of jumping or other high impact stuff is probably not the best. Again, there are some people that still do this. If that's kind of what your lifestyle was ahead of time, then a lot of people just want to get back to that. But it's not that you can't do it. We just kind of try to recommend not putting too much stress across it. So to kind of summarize everything, arthritis is a very debilitating condition that can really limit your day-to-day activities, your recreational activities. It's only getting more and more prevalent. So as we get older, we get more pain in our hips and knees. More and more people are suffering from arthritis now. There are a lot of non-surgical treatment options. We always start with that. Therapy, strengthening, anti-inflammatory medications, injections. If it gets to the point where you're really not able to tolerate the pain or interfering with that stuff so much, and that's when we consider joint replacement. Hip and knee replacement is really probably the 2 most reliable surgeries over the past 30 years in terms of patient outcomes, getting you back to normal activities and doing well after surgery. And there's been even more advances with robotic navigation and computer-assisted surgery that's really kind of pushing the limit and getting patients recovering quicker, having excellent outcomes, and getting you back to doing your normal stuff as quickly as possible. So at this point, we'll answer some questions. I know people have been asking some questions as we go, so I'm just going to peek down here on my phone here. That's all I'm doing here, just to look at some of the questions. So looks like we have a few so far. So the first question is, how long? So if you need 2 knee replacements on, how long after 1 knee replacement can you have the other knee replaced? That's a great question. We get that a lot. So it makes sense that if you have 1 bad knee, chances are you might have another bad knee. Sometimes we can do them at the same time. That's a bigger surgery where you're doing both knees. It's a longer anesthesia. Obviously, it takes about twice as long. The recovery is a little bit harder, but then once you get through that, then you don't have to go through a second surgery with anesthesia and the whole recovery again. Some people prefer to do it that way. We typically reserve that for patients that are very young, active, no medical problems. So typically, under 65 or certainly under 70. And that are more motivated to do that. Most of the time we don't do that. We do it kind of in a stage fashion. We do one side first and then the other side. On average, we wait about 3 months in between, and that's really just to give you enough time to heal. We like to see you back in 2 weeks, make sure you're doing okay. See you back in 2 months, and if you're at that point at the 2-month visit where we think you're comfortable and want to pursue the second knee, then we kind of schedule it for 3. So probably on average anywhere between 3 and 6 months, but probably the soonest is about 3 months. Now, the second question here is, how long after a hip replacement can you get back to sports, such as golf, tennis, skiing, etc.? That's another good question. So, part of this is we want to get you active and doing things. It really depends on the activity for stuff like that. For golf, tennis, I'd say probably about 3 months just to be safe. The first month, you're going to be just recovering, making sure everything's, healing fine. Part of the hip replacement is that there's a couple different ways for the implants to be attached to the bone. With hips, we typically do it with like a non-cemented, where it's just we rely on the bone ingrowth onto the stem, whereas knees, we do it with cement. With the hips, that means that that process takes a good 4 weeks, 6 weeks or more even though it's stable from the beginning, it takes that long to grow onto the bone before it becomes fully solid. So because of that, we don't want you doing too much to kind of loosen that. So if you get a little bit of motion from doing too much stressful activities, that can get loose. So that process takes about 6 weeks, but during that time, you can be walking and light exercise bike and stuff like that. But the golfing, maybe at 2 months, doing some light like chipping and putting, that kind of stuff. Anywhere between 3 to 6 months between golf and tennis and other higher impact stuff to really bad. I'd say at least 3 months before you start doing that stuff. Another question, how long does a joint replacement last in terms of like how many years does it last? With the technology that's been advanced over the last several years, the implants that we use are very high resistant to wear properties. So typically a hip or knee can last 20 years or more. Most of the time it does. Doesn't mean it always will. Some of the things that can prevent that from happening are infection, which we try to minimize that. A loosening. So sometimes if for some reason that implant just never gets stable, whether it's the bone doesn't grow onto it, or if that cement interface between the bone and the metal implant gets loose, or if that plastic kind of rubs away over time, that can create particles that loosen everything. And sometimes that happens earlier rather than later. But on average, you're getting at least 15, but a lot of times 20, 25 years or more. Sometimes we see people coming in that had hip replacements 30 years ago and they're still in good condition. A lot of that also depends on how much wear and tear you put on it. So the more higher impact stuff you do, or the younger you are when you have it, the more likely it might wear out a little bit sooner, not last quite as long. Next question is, how will I know when I'm ready for surgery? It's a good question. So it kind of comes down to some of that stuff we talked about earlier, where it's if this is something where it's debilitating pain, where it interferes with your everyday activities, where you have a hard time lifting your hip up or your foot up to put on your socks and shoes, getting in and out of the car, if you're not able to go on walks that you used to go on, if you used to play tennis or golf and you can't do that anymore, if you can't be as active with your children or your grandchildren. Those are sort of the functional things we look at. But then on the other side, we also like to make sure that you've done some treatment. So if you've done all that and you've said, I've just been dealing with it, I haven't had anything yet, we like to see that you've tried some anti-inflammatory medications, some strengthening, some therapy. Injections, you don't always have to do injections. Sometimes the joint is so bad that we just, it's not necessarily going to work, and that just, gives you a little more time maybe, or it gives you a little bit of relief, but you don't necessarily have to do the whole progression. But if you have those symptoms and it interferes with all your activities and you're not getting relief from the typical treatments that we use, then I think that's time to consider, hip or knee replacement. But I always say it's an elective surgery to improve your quality of life. It's not like something that you come in and you have a broken hip or you have a heart attack and you need something done. This is something that it's your choice. It's something that should be decided between you and your surgeon, and after evaluating you and kind of going over everything. But it's I always say you'll kind of know when you're at that point. You kind of have an inkling when you get there usually. Another question is, if the mechanical implant or replacement is loosening, how is it fixed? So if it does get loose, a lot of times that typically would require another surgery, and the surgery really just depends on what is actually loose. Is it the whole implant? So if it's a hip replacement, sometimes just that plastic liner wears out, and that liner is actually something that, even though it's locked into place, we can go in there surgically and remove that and remove the ball that's on top of the stem and keep the socket and the stem in place and just replace the ball and the liner. If the whole thing is loose, then it's a surgery where we have to take everything out. Similar with the knee, if that gets loose, we're talking revision surgery where you have to go in and remove the implants that are in there. And sometimes part of it is still fixed to the bone and part of it's not. So you have to sometimes it's certainly a little more invasive than a primary or regular knee replacement. And then we typically replace it with similar implants that are just a little bit. Same thing where it's a femur and a tibia, but typically it's a little bit bigger, a little bit longer. So you lose some of the bone, or we kind of bypass some of that area where it's loose and try to get a little more fixation, maybe more in the canal, or where the bone marrow is, or the canal. But typically, if it really is truly loose, then it does require another surgery to fix it. The question is, after a partial knee replacement, other part of the knee, will the other part of the knee wear away? Yeah, so that's a good question. So if you have a partial knee replacement, chances are, so if you have arthritis just in one part of the knee, at some point, the other part of the knee is going to wear out as well. So, if you do, say, just the medial side of the inner part of the knee, your kneecap, and the other side looks great, typically that still lasts for several years, but over the course of time, that can, the other part can wear out as well. And if that happens, we can kind of treat it the same way initially with conservative treatment and medications and therapy and strengthening. But if it gets to that point where the rest of the joint is totally worn out, and a lot of times we'll do another surgery where we, take out that partial knee replacement and then convert it and do like a total knee replacement. So a lot of times if patients are, it's kind of borderline where you think you might be a candidate for a partial, but if you have any pain in any other part of the knee, sometimes we'll err on the side of just doing the total knee replacement from the beginning, just so you can avoid having another surgery in a few years. But certainly if it's very clear cut that it's just one part of the joint, then it's totally fine going with just a partial. But at some point, most likely that will wear out in the rest of the knee, and then you're looking at potentially another surgery at that point, which isn't as bad as like a big revision surgery because it's just part of the knee revising, but it still would be another surgery later on. Another question is, will my arthritic hip continue to deteriorate? So the natural course of arthritis is that over the course of time, it does get worse. So once you start getting, if that's the hip, that's the ball in the socket, if you lose that cartilage in there, once that starts wearing away, it's kind of slowly progresses over time. It's not, it's usually not an overnight thing. It's usually the course of years, but once you get some arthritis, whether it's from, rheumatoid or just wear and tear or previous trauma, sometimes people are born with like dysplasia where their anatomy is a little bit different, or the leg lengths are a little different. It will tend to deteriorate, but it's, most of the time it's over the course of years. So once you start getting some arthritis, when you have that first onset of pain in the groin or the hip or the side of the hip, then, a lot of times you're still talking years before you get to that point where you might need a knee or hip replacement. But the kind of the short answer is yes, it will deteriorate, but it's a kind of a slower, more gradual process. All right, so I'm just checking. Doesn't look like we have any more questions at this time. So I just want to thank everybody for joining us. Again, just hip and knee replacement. We're definitely always here to help you out if you have any concerns or any questions or need more information. Again, I'm a hip and knee joint replacement specialist, board certified specialist in hip and knee replacement. It's certainly been a pleasure putting on this webinar. It's definitely been interactive, which is nice. We've answered some questions, and those are all very good questions that we had. That very typical that comes up, and a lot of that's the same stuff we would talk about in the office when you come in. But it looks like I think we have another question coming in, so we'll wait a minute. All right, so that's a good question. So what is the time frame to return to work from a knee replacement if you do sort of office work? So yeah, so the hip and knee replacement, it really just depends on your job. So if you're doing more active stuff like construction and manual labor, a lot of times you're out of work 3 months or more. In this question, if it's more of like knee replacement and office work, that's more sedentary. So that might be more like a month or so. We don't want you going back too soon because the first couple of weeks it's we want to make sure you're safe, you're healing okay, there's the wound's okay, make sure you're progressing a little bit with therapy. But if it's more like a sedentary office job, maybe 4 weeks to 6 weeks. If it's more a higher intensity labor job, it's 3 months or more. Part of that too depends on it's not just the job itself. You have to be able to get there. So if you have someone drop you, that's one thing. But if you need to drive there yourself, you got to make sure you're comfortable, driving and getting there. And once you get there, you can potentially sit or put your leg up or do what you need to do. But on average, anywhere from 1 to 3 months out of surgery, depending on the level or activity of your job. All right, so I think we're all set. If there's no other questions, then once again, I want to thank everybody for joining us. It's been my honor to kind of talk about this and go over hip and knee replacements. And stay tuned for some more webinars in the future. We're hoping to do this, kind of make more of a series out of this and bring you some more information right to you in your home. Thanks, everybody.